Hi, I'm Jack Cush with RheumNow, and we're going to have a mini panel discussion, myself and my best friend Janet Pope.
Hi there.
Yeah, we're having a good meeting.
It's been a really good meeting.
1 to 10, what do you think of this meeting?
I think it's an 8.25, repeating.
That's pretty good.
It is pretty good.
That's nice. I must say it's the same thing. Sometimes we come and it's hard to be impressed, and I think I've been impressed by a bunch of new things. I want to talk about rheumatoid arthritis and the high points for you at this meeting. What comes to mind when you think of rheumatoid arthritis and high points? What will you tell your fellows when you get back?
Right, so there's a couple practice changes, and then surprisingly, and not surprisingly, but reassuringly more of the same, which is always a good thing. So some of the practice changes are the flu shot data, that there's certain flu shot, one might be actually more effective in people with immune-related diseases. However, whether that pans out to being different for preventing influenza, who knows, but still to get the flu shot, because we saw the decreased mortality, decreased infections, all cause is decreased in people who get the flu shot, and that in Canada is suggested for everybody.
So the high dose flu versus the standard dose flu, obviously it's available. How often do you use high dose flu vaccine in your practice?
Right, in general I don't, and I wouldn't know in whom to use it. I would think that in general it'd be severely immune suppressed chemotherapy kind of patients, but something's better than nothing, and we don't even know if it pans out to less influenza, but there are more antibodies. But I think it's still the flu shot is the message.
Absolutely, but this data, and I kind of always practice like you, something is better than nothing, so I always give them, they're in my office, let's get this done while you're here, as opposed to go searching for the flu vaccine, the high-dose flu vaccine, which is indicated in the elderly. But this data from McGill, 270 patients, very convincing, 2 to 3-fold higher seroconverters, really makes me think I really should be doing this in my RA patients. These are RA patients on either DMARDs or biologics. Worked for everybody except for rituximab, not so good.
I think it's tough to say, though, is more seroconversion translating to less influenza makes sense, but we don't really know that. And I agree, something is better than nothing. So we have, yes, get the flu shot in every room in big capitals. Yes, get the flu shot as though they've asked. And we facilitate by having it in the fridge. Because if you can facilitate, they can get it right then and there.
And there isn't good data on if you got the vaccine, how much protection you got, because it's only, they have good data on the serologic proof.
Exactly.
But not necessarily,
we don't know
but
the
they do have
relevance.
good proof about not getting vaccine and dying.
Yes.
And that's the problem. So it's like 17,000 deaths last year, 18,000 deaths in people who didn't get, in the United States who didn't get vaccinated.
And it encourages our patients to say, actually, it's super safe to get the flu shot. This is not a live vaccination at all, so it's safe to get it, and it can prolong your life.
Excellent.
I think there's one other take-home that I might have, and that would be the reassurance that looking at the JAKs, they had 2 presentations of these long-term extensions, plus there was data from databases, MarketScan and other ones. And the bottom line is they're not seeing an increased risk of infection over time. What we found, or not me, what others have found at the beginning still persists, but the rates aren't going exponentially high or anything like that. And that VTE is still something we're going to talk about. I think the data are real. Whether the risk is going to even lower over time or not is tough to say. It was higher in the RCT than long-term extension on the baricitinib data, and whether it's a class effect or some drugs and not others. But the bottom line is not to maximize a rare event, but to really get the patients better and to know that if they're on treatment, the safety seems to be very consistent over time.
One of the messages that I find myself teaching a lot lately, which we know because we live it, but often most people aren't reminded of it, and by patients don't know, is that the longer you're on a drug, the safer it is.
Absolutely.
So all that long-term safety data, which I generally don't like, really does help me a great deal in dealing with patients who continue to worry, the more I take methotrexate, the more I'm rotting out my liver. Well, that's actually not true. The data is very clear that if you're going to get problems with methotrexate, it's going to be in the first year. The same can be said for almost most drugs. And I wouldn't say all drugs, but most drugs. And the ones our patients worry about, the longer they're on them, the better they're going to do, including, I say, in the case of VTE. The long-term data on VTE is not impressive and not related to the drug. So again, I think that it is incumbent upon us to remind the patients this is a good thing you're doing. You're not harming yourself by long-term therapy.
And I'm going to agree partially. So it's a bit circular. If you're on it and you're still on it, you've probably done well, the drug works,
Right.
and you've tolerated it, and you haven't had major serious adverse events.
Right.
So you kind of get people channeled into that. But in general, I always think there's adaptations. So the initial risks are things like cytopenias with our DMARDs, some transaminitis early, rash, intolerance.
Right.
But there is a long-term risk of liver toxicity with methotrexate, but it's very low,
Right.
and that has been borne out. We have either different patients or different problems compared to in the 70s and 80s in psoriasis when it was given daily and had a real problem. We just don't see that, which is really great. So I think what you're telling me is totally true. Plus, life happens. If you live long enough, you'll actually die.
And let's hope you do live long enough to die. What about, again, always at these meetings, always hard to know where it's going. In the United States especially, we've got, I think, 5 biosimilars approved in the rheumatoid space. We're largely not using much of them. We're using some of the infliximab biosimilar, although it's not very well discounted. You have biosimilars in Canada. What's been your experience so far?
Right, so we actually just got a second infliximab, so we have 2 infliximab, 2 etanercept, and as we all know, more will come. The market penetration is very close to the US at about 7% of all biosimilars across the board, and I think there's 2 issues. One issue is we don't want to rock the boat when a patient's been on, in general, 3 DMARDs or 4 DMARDs with RA before they get on something. So the path of least resistance is to really say, you're doing well, let's do your follow-up, and maybe let's talk about the safety of,
Right.
you're getting your drugs monitored, you should stop smoking. You only have so many minutes in there. But also I think there's a fear, so there's complacency on both parts, but there's a fear of the nocebo effect. Because I believe most people think that a biosimilar, when Health Canada or FDA says there's etanercept, I think people believe that etanercept exists.
Mm-hmm.
But if patients are switched and they break through, people feel badly, because what do you do next? If you went backwards to the other product, backwards meaning recycling backwards,
Right.
It doesn't make sense if you've actually broken through and the drug doesn't work, but yet some people will have nuisance side effects and say, put me back on the other one. So I do believe in Canada, until it's mandated, we won't have the uptake. And why should it be mandated? To actually save money. If you should do equally well, and it's mandated, we would help people go through it. And if you have positive advice, they've shown that at several meetings, if you have positive talk to the patients, Health Canada, FDA has approved other etanercepts. I'm only talking about it because it saves the system money. If you have that kind of positive thing, you should do the same, not worse, not better, but the same.
Right.
I think that helps people transition, and most of my patients don't say no. But if they do, they have every right to say no at this point in time, because I don't have a medical reason to switch them. So if their reason is they get co-pay help, if it's an infusion and it's closer to them, if I switch they have to drive further, then their reason will always trump mine.
All right. We go to, Artie and I go to Sweden every year for the last 4 or 5 years to lecture in January, and when they started introducing infliximab biosimilar there was a great deal of reluctance. There was a lot of concern, a lot of combustible rheumatologists talking about this. Over the years, it's now a non-issue, and now they're at the point that they're switching from the biosimilar to another biosimilar back to the originator.
Depending on the cost
based on
per
cost,
cycle.
right? And
Yes.
the government's determining it, and it's being well received by the rheumatologists because they know it's a big savings. They don't see much in the way of trouble. Patients are accepting it, and I think one of the things I'm seeing is that the issue of patients and patients' acceptance is largely dictated by the physician attitude. If your
Yes.
attitude as the physician, as the prescriber is, darn it, I wish I didn't have to do this, they're making us do this, and if you have no confidence in this or don't believe it's the exact same, then the patients worry, and then they get all kinds of effects that they shouldn't have, and then
Yes.
and then you're faced with, can you go back? Do I have to go to another therapy? Am I going to actually
Right.
cost the patient more? Am I now risking more? So I mean, physicians need to be comfortable. They need to buy
Right.
in and understand this.
So we need practice talk. So I tend to run basically little workshops on communication, looking at risk, benefit of anything, but including practice talk there, because it's not just what you say, it's your body language, and people that say, I think you'll do just fine, the body language says no, so
Right.
that's one thing. The other thing is, we do debate where are the savings. So if it went back for innovator drugs to be funded for my patients, or if it went back to a more cohesive model of care for my patients, of course, possibly I, meaning the rheumatologists in Canada, I'll speak on behalf of them, would embrace it probably more fully. But our Canadian patients, they're very used to generics. I realize a biosimilar is not a generic, but they get the idea that if we prescribe drug X, they'll get ApoX, NovaX, DivaX, whatever.
Right.
They realize that their drugs change, and that in general, for most of them, there's not a problem. A rare person would say no substitution, only on this, because one it seems to be absorbed better for me than another. But that's the uncommon. So I think if patients got on board to know that we're in this together, that these are costly items, and that the market is growing, and the market's growing meaning the next 4 patients, possibly even one in their family with another autoimmune disease, will have to be treated. We actually have to have resources to do what is needed for all our patients, but the patient in front of me, while I'm talking to them, is obviously the most important at the time.
I really believe that the biosimilar story is going to be playing out sooner and faster in Canada than the United States, which means I'm going to be looking to you to gain confidence on how it's going to play out. So,
and I can tell you, I've tried to switch many people, and as I say, very little resistance, and the only reason I'm switching it is for cost savings.
All right, Janet, thank you very much. This is very interesting.
Great, thank you.
Come to ACR, this is where you learn.